Good afternoon, everyone. I'm Xu Shanzong from, and today we are going to discuss the bone and joint tuberculosis. We all know TB is a great challenge for human beings, and we all know it's a global emergency. Here in the WHO, we've announced the tuberculosis in the beginning of the 21st century, declared as a global emergency. And tuberculosis, that was main capital, that would mean some capital deaths of this kind of disease in the far away. And the tuberculosis, we should know these kind of things, that despite the rather scant attention given to the tuberculosis, it remains a leading infectious cause of deaths worldwide. And approximately 3 million people per year die of the tuberculosis, and it is complicated. In some developing countries, more than 50% of the population is infected, and the mortality is as high as 104 per 100,000. We should know the historical background. And here there is a very important man we called Hippocrates. He was the first clinical demonstration of this kind of disease. And in the 500 and 1500 AD, the Roman occupation of Europe spread to the Britain. And then 1650 to then 1980, it was a wide patch of the Europe, causing 5 deaths. And this man is very important. We should remember this person. And that means Robert Koch. He have a great description for to conquer this kind of disease. He discovered studying the technique that can identify the tuberculosis bacillus, and the definition of diagnosis was made possible, and thus the treatment could begin. That was happening in 1882. And in the tuberculosis, we are first doing the phenological things, and the phenological discoveries have its own history. And we just look at this slide and go next. And this man, Selman Abraham Worksman, he awarded the Nobel Prize for the discovery of the streptomycin in the 1952. Okay, this was a primary drug for this kind of TB disease. And we also have a lot of other drugs, the PAS and isoniazid, and the pyridazimide means PZA. Okay, in the 1952 and 1954. And in our years, we still have developing new phenological things to treat TB. And the tuberculosis is transmitted primarily through inhalation of the ingestion of the Mycobacterium tuberculosis or the M. bovis. This picture is the Mycobacterium, and this is the Mycobacterium. We have genome of the Mycobacterium and documented. We should know this kind of disease have re-increased cases reported in our years. The reason is quite different. Before it was poverty was the main reason. And nowadays it was currently infected with HIV, the transplant, the alcoholism, the drug abuse at centers. And the TB have its predilection sites. It can, the first one is spine. Of course, that means the expulsionary TB. And the secondary was the knee and the hip. We know the TB can divide it into the pulmonary TB. The pulmonary TB is a major public health concern, and the extrapulmonary TB. We call it bone and joint TB is one kind of extrapulmonary TB. Extrapulmonary TB involved is noted approximately 14% of patients, with 1% to 8% having osseous disease. Approximately 50% of patients with osseous tuberculosis have pulmonary involvement, and 30% to 50% of those osseous disease have lateral involvement. We should know the pathology of this tuberculosis. According to the anatomical side, it's divided into bone tuberculosis and synovial tuberculosis and the joint tuberculosis. The basic pathological features could be exudative and the casus necrosis and the other proliferative tissue reaction. First is bone tuberculosis. If we say a bone tuberculosis, it can be a calcaneous bone tuberculosis in the center and the edge. And we could see the cortical bone tuberculosis, always in the osteoporosis and the bone sclerosis. And the third way was metaphysis tuberculosis. We also have synovial tuberculosis. We always have swelling, effusion, and joint capsule contracture, and synovial fluid fibrin precipitate formation of white growth loosen bodies called tuberculosis gland of the rice body, and we have joint tuberculosis. There are different clinical manifestations for this disease. The patient may have acute or chronic symptoms, and the constitutional symptoms include fever, chills, and cough, and accompanied with pelvic pain and weight loss and fatigue. The patient may have intramedullary granular impulse and the arrocranium with segmental collapse with anterior vision and the gibbous lesions, which we also call the post-dilation disease, and the perispinal abscesses with sinus extension to the skin also may arise and extend through tissue plans to reach intraperitoneal structures. Patients present with pain, weakness, and in the late stage, the paresthesis always occurred in the spinal TB. We should know the TB have different extension ways. The first was lymphogenous, and it can be hematogenous, and it could be cartilaginous extension. And lymphogenous and the hematogenous spread has been implicated in the thoracolumbar lesions, but less often in cervical or sacral lesions. Spine involvement. The spine is the most common, which means the 30% to the 50% site of osseous involvement, especially in elderly individuals. A primary complement lesion may be discovered from the pulmonary or urogenital system or from the unknown source. If this kind of disease have a spine involvement, we have different types of this. We could call it the H type, the central type, or the accessory sclerosis. In the H type, it's usually active spine lesions involved a particular segment of two vertebral bodies and the corresponding disc. And the central type, was the less frequent one, lesions occur centrally in the vertebral body. And the accessory sclerosis, was rarely the posterior element of the spine and the only sides affected. We have joint involvement in this kind of TB. It was typically affected at the major weight bearing joint of the lower extremities. Lesions involve the articular cartilage, which eventually is separated by granulofibrous tissues. The trabecular zones of the bone are affected with subchondral involvement, affecting the weight-bearing capability of the joint, which may progress to significant accelerated joint surface degeneration. Peripheral joint involvement, a patient may present with a limb and a joint that is worn, swollen, and has a decreased range of motion. It can be confused with other rheumatological conditions like gout or the rheumatoid arthritis. We want to diagnose the sclerosis. We should use these image studies. First was the plain X-ray, the CT, the MRI. If we're doing a plain X-ray, we should know the synovial infiltration and the periarticular erosion and the periarticular bone mass, the progression to fusion. Rare but can be colored, and a focal segment collapse with anterior region and the gibbous formation. This is X-ray for the chest. We still emphasize the chest X-ray should be done even in the primary sclerosis. It was a malinudal infiltration about or behind the clavicle without the pelvial effusion and unilaterally or bilaterally. The MRI and CT, the MRI and CT also can provide more detail and delineate the disease in earlier phases. This is a picture, shows X-ray. This was tuberculosis here, and in this position was an abscess, around this feces. This is a tuberculosis of calcaneal sperm. This is a tuberculosis around the knee joint, and this was an X-ray. This was an MRI showed the tuberculosis in the spine. It's quite dark here. And this also MRI. We can see the perispinal abscess here around the spine. This is a tuberculosis infection of the spine. And the CT shows the erosion of the bone, and we have lytic lesions here and here in the bone, in the vertebral. And also this CT shows the bone have a lot of wormhole-like lesions. We should also do the laboratory tests. First, we should do the blood routine towards frequently the white blood cell count is normal. And we do the ESI and CRP, maybe evaluated or no. We do the PPD test, means a skin test, can be false negative rates, can be as high as 20% to 80%. If you do PPD test, you should know that. And the T-spot is a new way to identify these tuberculosis. And the culture. The culture is the gold standard. We also know the bone culture taken from disc involvement are positive in 60% to 80% of cases. And sputum and the gastric culture of the patient with pulmonary involvement usually are positive, is more than 50%. This versus skin test means PPD. You're using this to make sure how centimeters is larger. Then this shows the sputum investigation. Culture will review the presence of the mycobacterium and tuberculosis, and the patients stay infectious for as long as the bacteria is excreted in this sputum. T-spot is a new way. Means space organ cryotype typing. And this presents the absence of 43 spatial regions found in the direct repeat region of the MTB gene. We have know the full genome of these bacteria. Biopsy. Biopsy in patients with pulmonary involved are positive in 70% to 86% of the cases. And the differential diagnosis. There are different diseases which was quite similar to the tuberculosis. The first one was rheumatoid arthritis, and the second one was ankylosing spondylosis, and the osteomyelitis. There's the septic arthritis, the bone tumor, the intervertebral disc herniation, the degenerative spine, and joint diseases. This picture shows ankylosing spondylosis. You can see there's a fusion before the vertebral, and this vertebral is quite square. It's a purogenic spondylosis. This was not caused by the TB bacteria. It's caused always by their S. cereum. And this was a spinal metastatic tumor. It can jump to the vertebral, and can be multiple things happens. Non-surgical treatment. We should know the non-surgical treatment of the tuberculosis. The primary treatment objective for the tuberculosis of bone should include the halting the infection, and the limiting of the deformity, the maintaining of the mobility, and reducing the discomfort. So, if we are going to achieve these goals of the non-surgical treatment, we should use chemotherapy to halting the infection. And we use the relative rest and the guided remobilization to limiting the deformity and maintain the mobility. We use pain management and adjunctive splitting system. Means it could be passive or dynamic or functional, and casting techniques to reducing the discomfort. First, we talk about the chemical therapy. The chemical therapy is very important in the tuberculosis. There are various combinations of medications available, including isoniazid and rifamycin, and the insulinbutyl, and the pyrazimide, and streptomycin. This is a table for use to the treatment of tuberculosis. And the most important one was the isoniazid. Here was very essential. That was a first-line drugs, and the rifamycin is here also is essentially the first line. And other drugs in the first line is the pyrazimide and the insulinbutyl and the streptomycin. And we in the clinic in these two drugs is very important. Also, we got other second-line drugs like quinones and the other drugs, a lot of drugs. Okay, and we should know that INH and rifampicin are very important, most potent and bacterial risk. And TB can be treated efficiently with INH gel plus rifampicin. And the mono-resistance to those one of them can be treated effectively with region containing of the other agent with very low failure rate. It's only about 2.5 to 5%. And the failure rate with the INH plus IF resistance is 44% in non-HIV and 70% in HIV patient. So the duration required for cure doubles to triples. And the definition of the multi-drug resistant tuberculosis. This was concept is very always talked in the clinic here right now, and the resistance to the isoniazid and rifamycin. We call this kind of tuberculosis is a multi-drug resistance. And another drugs called XDR-TB means extensive, or we can say extremely drug resistance tuberculosis. So MDR-TB applies resistance to a second-line injectable drug such as amikacin plus quinone. Then we can say this kind of TB is XDR-TB. Yep. 为什么这张换那个不是？
那么先停一下。先停一下。
停下不对。
这张幻灯，我刚才就觉得我那套幻灯好像，我原来考的是老文本上去了呢。咋了？
Epidemic orange, the primary drug resistance and the initial drug resistance, the secondary drug resistance, and the acquired drug resistance. What is medical drug resistance to tuberculosis? We have formally introduced the medical drug resistance is a TB that is resistant to the least two best anti-TB drugs, isoniazid and the rifamycin. These drugs they considered the first-line drugs and are used to treat all the persons with TB disease. This is a definition of MTB drug resistance. We have mono-drug resistance, the poly-drug resistance, the meta-drug resistance. Short for the MDR, and the extensive drug resistance is XDR. Okay. You can see the table and after class, okay. And this MDR and the XDR tuberculosis was worldwide thing. We can see China is here. Our country is about 3% to 60%. And we have a rapid raising from the resistant tuberculosis. WHO have emergency alarming. We know that tuberculosis have a lot of drug resistance problems. That was a great challenge today. And the alarming raising of resistant TB, we can see the TB boundary countries in the former and the center region was about 50% of cases resistant to at least one drug, about 20% was MDR, and the XDR TB proportion also higher. And MDR and XDR TB was essentially a man-made problem. And we can also see Lancet have articles about the XDR TB, and this was more important today. And the impact of the drug resistance, if these kind of things happens, it can prolong illness, and it can increase mortality. It prolongs periods of infectious with increased risk of transmission of resistant pathogens to others, and it can be indirect cost. It can be increased direct cost. Who is at risk of getting the MDR TB? Also, we should know the drug resistance is more common in people who, firstly, do not take their TB medicine regularly, and do not take all of their TB medicine as told by their doctor or nurses, and they're developing active TB disease again after having taken the TB medicine in the past. They come from the areas of the world where drug-resistant TB is very common, and have spent time with someone known to have drug-resistant TB diseases. So all these factors can take a risk, high risk of these drug-resistant TB. The chemotherapy principles we should know is we should take their medicines as early as possible, and we should combination of the ephemerological agents. We should private dose of the drugs for different conditions and different peoples. We take drug regularly. That's very important. You should educate your patient. Take drug regularly, and full duration of the chemotherapy. Chemotherapy, the ephemerological agents, and the duration of the treatment depend on the patient's age, dismission of the disease, and accompanied medical communications. For example, the AIDS, the chronic gland failure, and so forth. Treatment duration can extend from 6 to 12 months. That's important. You should keep the duration from 6 to 12 months, and the patient less than 3% are resistant to material chemical therapy agents. And as part of their chemotherapy, we have surgical treatment. For the astrotomy, including biopsy, the synotectomy, and with bone grafting and of article erosion. We can do the curettage and the bone grafting of the extra-articular skeletal lesions. We can do resection of joints. We do resection of bones. We evacuating or exciting of the soft tissue abscess. We can do arthritis surgeries. We do amputation surgeries. And we should know the indication for surgery. What kind of patients should do surgery? First, invaded sequence joint, and the abscess, sinus or synovial tuberculosis after non-surgical treatment. And the second was spinal tuberculosis. Spinal tuberculosis is quite special because the spinal cord and nerve symptoms, and people may have paralysis from this kind of disease. The goal of the surgery, we should know the tuberculosis abscess and the question, the cheese-like substance, and the tubercle granulation tissue, and the sinus completely clear should be, and the wounds caused by the tuberculosis with relatively fresh and healthy. amputation. In some cases, we can do amputation surgeries. Amputation is indicated when extensive tuberculosis involvement tenders less radical treatment unsuccessful, especially in adults with extensive lower extremity involvement. And extensive amyloid disease adds to the desirability of the amputation. The operation should be carried out proximal to affected joint. And in children, lower extremity amputation also is justifiable when tuberculosis osteomyelitis result in marked shortening of the limb. And the spinal tuberculosis, I say this was a very special pattern. And this was a probability of the occurrence should be lower thoracic. The first position is the lower thoracic, and the thoracic lumbar, and the cervical and the lumbosacral. There are different types of the spinal tuberculosis. We have subtypes for this central type, the H type. H type means more than 2 of the most common, and the subspecies peristeel accessory tuberculosis, which was quite rare. And in the spinal tuberculosis, the patient always have pain, and you can touch a mass. This mass always means an abscess. We call this kind of abscess is a cold abscess. In the cervical spine, and the posterior of the pharyngeal wall, and the anterior of the posterior triangle, always lines. And the thoracic, in the thoracic, the cold abscess is always in the paravertebral, and in the lumbar spine, the cold abscess always hiding the lumbar triangle iliac fossa and the upper thigh and the ground below the inner side of the lower thigh of the inner rear. This picture shows the paraspinal abscess. It's a cold abscess. It's around the lumbar spine to the iliac fossa. It can run to the thigh. Paraplegia. Paraplegia can happen in the spine. Tuberculosis can direct compression of the necrotic tissue caused by. This was the first reason, was a direct compression. And the second reason for the paraplegia is dural inflammation and the acromoditis caused thickening and narrowing of the pector of the spinal cord. And the third reason is the epidural space tissue infiltration caused by dural sac compression and spinal cord compression caused by spinal cord blood supply injured. And the fourth reason for this paraplegia was spine biochemical changes. This is a picture shows the spinal tuberculosis after liver transplantation. You can see these kind of positions was infected. And the MRI shows these 2 vertebrae was involved, and we can see the abscess formation. Thank you for today's class. We should know the World Tuberculosis Day is March the 24th, and may the world tuberculosis can be cured, and human beings can win this battle. Thank you.